Hello, students. Good evening. Welcome to one more Why Conundrum. In this session, we'll be discussing about a famous question. It's regarding why the BP is changing when you combine two different drugs, which is famously named as vasomotor reversal. So we're going to talk about why is there a development of vasomotor reversal. It's already been named as vasomotor reversal of Dale. It's because Professor Dale established that particular phenomenon. So we'll be discussing about that. First of all, please note down that we have a famous mnemonic that is ABCD. ABCD, which means alpha 1 receptor will be producing vasoconstriction, whereas beta 2 receptors will be producing vasodilatation. So the take-home point here is, see, whenever there is stimulation of sympathetic autonomic nervous system, whenever the sympathetic autonomic nervous system is getting stimulated, from there, those neurons which are supplying to the blood vessels, will be containing two different receptors, 1, 2, 3, 4, 5, 6, 7, alpha 1, 6, 7, beta 2. Because we know both alpha 1 and beta 2 are G protein coupled receptors. Even if we don't know anything about G protein coupled receptors, don't worry. So this is the type of a receptor. This receptor is alpha 1, whereas this one is beta 2. From the neurons, whenever there is stimulation of sympathetic autonomic nervous system from the brain, from the neurons, there will be release of certain molecules named as adrenalins or noradrenaline. The primary neurotransmitter is going to be noradrenaline. So we're going to writing up noradrenaline. Please note on that noradrenaline has got no beta 2 activity. Noradrenaline will bind only with alpha 1 receptors. So this will go stimulate the alpha 1 receptors, thereby produces what? Vasoconstriction. As we have discussed here, alpha 1 produces vasoconstriction. Whereas if in case there is release of adrenaline, this might have activity in both alpha 1 and beta 2 receptors. So what if it is interacting with beta 2? This will be producing vasodilatation. So two different or opposite responses, which is produced by the stimulation of sympathetic system itself. Okay. Now this point is cleared right now. Now we'll look into what exactly is the meaning of vasomotor reversal. See, adrenaline, as I've told, noradrenaline has got no beta 2 activity. We have discussed that already. Noradrenaline, no beta 2 activity. Adrenaline will be having action at all the receptors. So finally, what happens is whenever there is increased concentration of noradrenaline, there will be only vasoconstriction, because that's the concept of noradrenaline, because it has got no beta 2 activity. Whereas on the other hand, your adrenaline will be acting at all the receptors. All the receptors means whenever it is acting up at alpha 1, it might be producing vasoconstriction. If it is acting at beta 2, it will be producing vasodilatation. Both these responses are possible with adrenaline, but which will be seen in the patient. That is primarily these two different responses are dose dependent. Dose dependent means at low dose, medium dose, and at high dose, it tend to have a selectivity at different set of receptors. For example, when you administer adrenaline at low doses, it will be more beta 2 selective. Whenever adrenaline is administered, or when the concentration of adrenaline is at low, it's going to be more beta 2 selective. Whenever it is given at high doses, there will be alpha 1 followed by beta 2. Is that clear? Whenever it is administered at high doses, or when the concentration there just nearby the blood vessel, if it is very much high, there will be initially alpha 1 followed by beta 2 activity. So if we just put it up, if the same concept is put up as a graph format, consider we have the blood pressure. The blood pressure is normal here, and you have administered adrenaline for the patient. Okay, adrenaline is administered at high doses. Now the BP is normal, this is not ECG. If the ECG is flatline, there's no use of it. I'm talking about blood pressure here. So when the blood pressure is normal, you administer adrenaline at high doses. As we know, initially there will be alpha 1 followed by beta 2. Alpha 1 tend to produce vasoconstriction. What will happen whenever the blood vessels are getting constricted, buddy? Whenever the blood vessels are getting constricted, vasoconstriction, there will be increase in the blood pressure. Whereas whenever there is vasodilatation, there will be decrease in the blood pressure. Two opposite responses, as we have discussed previously. I have explained that with the vessel concepts. Now I have explained that in the blood pressure concept also. So vessels, whenever it is getting constricted, there will be increased blood pressure. Whenever the vessels are getting dilated, there will be decreased blood pressure. Okay. Now, what happens when you administer adrenaline at high doses? So initially alpha 1 followed by beta 2. Alpha 1 induced vasoconstriction followed by beta 2 induced vasodilatation. So initially there will be a rise in the blood pressure due to alpha 1 activity, followed by a profound fall in the blood pressure due to beta 2 activity. Again, after that, adrenaline is going to get broken down, reuptake, all the mechanisms will happen, and the BP will come back to normal. This concept, which is seen whenever adrenaline is given at high doses, is named as biphasic response in the blood pressure. Biphasic response means increase in the blood pressure followed by a decrease in the blood pressure. That is named as biphasic response. So if a simple question comes, we have seen lots of one-liners till now. The first question is, what is the response of alpha 1 and beta 2 receptors? Alpha 1, remember that ABCD mnemonic, alpha 1 produces vasoconstriction, beta 2 produces vasodilatation. Noradrenaline has got no beta 2 activity, adrenaline has got all the receptors activity. Now, when the same adrenaline is given at low doses, it is more beta 2 selective. When given at high doses, initially alpha 1 followed by beta 2. Three important points we have dealt. The fourth important point is the concept of biphasic response. As we have seen, initially an alpha 1 induced increased blood pressure followed by beta 2 induced decrease in the blood pressure. Okay. Now, whenever a patient is coming up to you and the patient has eaten up some food for which he is allergic to, and the patient is brought up to you for some during the casualty or in the emergency department, and the BP is very much low, around 80-50 millimeter of mercury. The BP is falling down because of anaphylactic shock, and you plan to administer adrenaline for the patient. What happens is, here's the BP. You have planned to administer adrenaline for the patient given at high doses because that's how the BP is going to get increased. But there is a small history in the patient, and that history is the patient is already under an alpha blocker therapy. Alpha blockers like prazosin or terazosin or doxazosin or phentolamine or phenoxybenzamide. These are the different alpha blockers which we currently use in clinical practice. Okay. What if a patient is under any one of these drug therapy already, and the patient has eaten up that allergic food? It might be peanut allergy, or it might be any prawn or any seafood allergy. It might be anything because of it. Now, the patient is landed up in anaphylactic shock. You don't know the patient's drug history. You have administered adrenaline at high doses, after which you have seen that your blood pressure was 80-50. I hope you remember that. Now, you administer adrenaline for the patient, but instead of increase in the blood pressure, what you see is normally what you should see, guys, there should be an increase in the blood pressure, right? That's the concept. But here, this will not be seen. Instead, there will be a profound fall in the blood pressure. Why? Because already the patient is under an alpha blocker therapy. When the alpha receptors are blocked, as we go back to the diagram here, when the alpha receptors are getting blocked, whatever be the dose of adrenaline is administered, even if it is high dose or even if it is low dose, it will be acting more and only at beta 2 receptor. Why? Because the alpha receptors are blocked. That's the reason why when a patient is already under an alpha blocker therapy and your patient is landing up in anaphylactic shock or any other shock and you administer adrenaline for the patient, instead of this increase in the blood pressure, there will be a decrease in the blood pressure. 80-50 was the presenting blood pressure. You administer adrenaline, BP will start falling down. That concept is what we call as vasomotor reversal. This concept is explained as vasomotor reversal phenomena, which is explained by Professor Dale. That's why it has been named as vasomotor reversal of Dale. This is the meaning of vasomotor reversal of Dale. but he actually used one another molecule to explain it. See, he was the one who found out that to give a demo to explain about this concept of vasomotor reversal, he used an alpha blocker, and that is an ergot alkaloid. He used ergot alkaloid as an alpha blocker. Okay, he didn't use any of these drugs. He used ergot alkaloids because that is behaving as a partial agonist agent. Ergot alkaloids behaves as a partial agonist agent at alpha receptors. That bond is going to be very much severe, very much stronger. That's the reason why he chose ergot alkaloids to be to explain, to showcase the concept of vasomotor reversal phenomenon. Well, that's it about the concept of how there is, or to say why there is a decrease in blood pressure after adrenaline. That's the concept of why that's the concept of a vasomotor reversal phenomenon. Thank you so much, guys. We'll meet up in one more Why Conundrum.